From Microbe TV, this is Infectious Disease Puscast, episode 18, recorded on December 21st, 2022. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. Now, on to the literature, shall we?
Now, Sara, I was going to change the introduction to the famous Sara Dong, because when I was at the American Society of Tropical Medicine and Hygiene meeting, apparently everyone listens to you. So you're now a crowd favorite, but all right, let's get right into viral. So remember to listen to This Week in Virology, clinical updates for COVID and monkeypox and lots of other related information. Hopefully one day I can be as famous as
I don't know about
Sara Dong, but anyway. I will start off with a sad article, but I think important. The MMWR Human Rabies Texas 2021 describes the case of a young boy aged 7 years bitten by a bat while he was playing outside his apartment home in Medina County, Texas. He informed his parents, however, no rabies post-exposure prophylaxis was sought because there were no visible bite marks, and the family was unaware that contact with a bat, including in the absence of visible bite marks, might cause rabies. Approximately 2 months later, the child was hospitalized for altered mental status, seizures, and hypersalivation, and ultimately received a diagnosis of rabies. Experimental therapies were attempted. However, the child died 22 days after symptom onset. So just a bit more to this story, because this is not common, but I think is an important educational case here. So on October 21st, 2021, the boy, aged 7 years, was evaluated at a freestanding emergency department. This is Facility A, for a 2-day history of right hand itchiness, right upper extremity pain. He was given an oral steroid and discharged home. How often has that story played out? The following day, he was assessed at a different hospital emergency department, Facility B now, for a rash on the right side of his head, right scapular area, right hand and arm, along with continued pain in his right arm. He received a diagnosis of presumptive herpes zoster shingles and was prescribed a 5-day course of acyclovir along with antihistamines and ibuprofen. 1 day later, on October 23rd, he returned to Facility B with delusions, worsening itchiness on his forehead, was discharged with diazepam for spasms and gabapentin for pain. Later that same day, he returned with nausea, vomiting, fever, 104 Fahrenheit, 40-degree Celsius, hypersalivation, change in mental status, including confusion, delusions, ultimately intubated for airway protection. That evening, transferred to Facility C, where he was admitted. Treatment was begun with empiric antimicrobial drugs for presumed central nervous system infection. Initial testing included cerebrospinal fluid, blood cultures, testing for herpes simplex virus, varicella zoster virus, enterovirus, mycoplasma, Bartonella, Epstein-Barr, cytomegalovirus. All tests later came back negative. On October 25th, a diagnosis of rabies was suspected after infectious disease clinicians solicited a detailed history that disclosed the bat bite approximately 2 months earlier. So a couple things I want to point out here. One is, and we've sort of repeatedly hit on this, calling that ID doc, right? I mean, I bet everyone that listens is an ID doc, but calling that ID doc sooner might have made a difference here. This is what we're known for, those detailed histories for which we are not well reimbursed, but which are great. So you should become an ID doc. But the other is that particularly bats here in the US, these tiny bites, you may not even feel it, you may not even see it. So this is always that, if you wake up and there's a bat in the room, assume the thing bit you. All right. So yes, I appear to have a thing for articles about rabies. After seeing a number of cases, I'm always drawn to try and understand this issue more. What a devastating disease, and also perhaps my inability to avoid interacting with animals is a foreshadowing of the saying that all physicians die of a disease in their specialty. Fortunately, cattle don't carry rabies, or I'd be a goner already. Um, yeah, my last trip to, Uganda, my buddy Kai, made the comment, "So, Dan, you seem really drawn to cows." Apparently so. Well, the article, Human Rabies Despite Post Exposure Prophylaxis, a systematic review of fatal breakthrough infections after zoonotic exposures, published in the Lancet Infectious Diseases. Here, the authors conducted a systematic review of articles published between January 1st, 1980, June 1st, 2022, to characterize breakthrough infections. After reviewing over 3,000 articles from across all of the continents. I guess they're including Antarctica there. They identified over 50 articles, which included a total of 122 breakthrough infections. Deviations from core practices were reported in the majority of the cases. Other possible cause for breakthrough infections included errors in the administration of rabies immunoglobulin, delays in seeking health care, comorbidities, and immunosuppression.
Well, I'll take us in a different direction, although there's some animal links in here. Uh,
Okay.
I took an article from the Lancet Global Health, the Qatar FIFA World Cup 2022, and Camel Pageant Championships increase risk of MERS-CoV transmission and global spread. So if you happen to have been living under a rock, the FIFA World Cup has been undergoing, but there was another simultaneous mass gathering nearby of a camel beauty pageant festival, which I actually didn't know about this part. But camels are a major reservoir for MERS-CoV, and humans can become sporadically infected through direct or indirect contact with infected camels or camel dairy products. And so the paper just kind of mentioned some of the updates as far as reported cases. So 2,600 people as of November 1st have been reported to have lab confirmed MERS, including a little under 900 deaths globally from 27 countries. And so the paper was really an alert to remind people about the possibility of spread beyond the Arabian Peninsula given these events, and especially because there's such a heavy respiratory infection burden this season. There's crowded healthcare facilities, and this is not surprisingly probably would lead to a delay in diagnosis as you sort of presume that it's one of the many other viruses that we're seeing in the hospital right now. And they kind of mentioned the importance of proactive surveillance and noted a large 2015 MERS-CoV outbreak in South Korea, which had at the time kind of highlighted the lack of clinical awareness and some gaps in infection control measures, which drove some of the nosocomial spread. So I took a quote to end this one out. The risk of visitors to Qatar returning to their home countries infected with MERS-CoV remains real. All public health authorities and healthcare workers, not only in the Middle East, but in all countries from where attendees of either event have traveled, should have heightened awareness of the possibility of infection.
Okay. Now I actually Googled this is a beauty contest for camels, right?
Yeah.
Really
Yeah.
quite interesting.
Yeah,
Yeah.
I Googled it after I read this just to get some images, and it's pretty great.
Yeah, I never found camels to be, beautiful, but I guess beauty is in the eye of the beholder. So.
Well, it's because you're a cow person. You've now known.
Yes, I am safe for MERS. I just ignore the spitting camels. All right. This falls under articles I found really interesting. Yes, our first preprint, I think. An update on eukaryotic viruses revived from ancient permafrost, posted on BioRx. Let me share the abstract. 1/4 of the northern hemisphere is underlain by permanently frozen ground, referred to as permafrost. Due to climate warming, irreversibly thawing permafrost is releasing organic matter frozen up for up to a million years, most of which decomposes into carbon dioxide and methane, further enhancing the greenhouse effect. part of this organic matter also consists of revived cellular microbes, prokaryotes, unicellular eukaryotes, as well as viruses that remained dormant since prehistoric times. I think we need theme music at this point. While the literature abounds on descriptions of the rich and diverse prokaryotic microbiomes found in permafrost, no additional report about live viruses have been published since the two original studies describing pithovirus in 2014 and mollyvirus in 2015. This wrongly suggests that such occurrences are rare and that zombie viruses are not a public health threat. To restore an appreciation closer to reality, we report the preliminary characterizations of 13 new viruses isolated from 7 different ancient Siberian permafrost samples. So, what do you think, Sarah? Do we now have to add resurrected zombie viruses being released from the melting permafrost to our list of things to keep us up at night? Should we reread Smilla's Sense of Snow by Peter Lowe?
This is very, very festive of you. Though this should have come out closer to Halloween, so it would have been more.
I'm thinking
Um,
the icy winters now. So when
yeah, it's
people
true. It's
complain,
right in between.
things are,
Well, I will take us over to our bacterial section. Please be sure to listen to This Week in Microbiology. I'm excited to talk about this next one because I think it's quite interesting. So in New England Journal of Medicine Evidence, the paper Colistin Monotherapy versus Combination Therapy for Carbapenem-Resistant Organisms. So this is the Overcome trial, Colistin Monotherapy versus Combination Therapy. So this is a randomized, double-blind, placebo-controlled trial trying to look at outcomes of carbapenem-resistant gram-negative bacilli. It was an international trial with enrollment in the US and Thailand, Taiwan, Israel, Greece, Italy, and Bulgaria, with data collected from 2012 to 2020. And so the eligibility criteria were adult patients 18 years and older, those that had pneumonia and or bloodstream infection caused by XDR Acinetobacter, XDR Pseudomonas, or CRE, and those with in vitro susceptibility to colistin with an MIC less than or equal to 2. And so all the patients received IV colistin at 5 mg per kg and then 1.67 mg per kg Q8 subsequently. And then they were randomized to either get an IV carbapenem, which is imipenem, and then later meropenem, which we'll come back to, or placebo. And people had a 7 to 14 day course determined by the trial personnel. The primary outcome was all-cause 28-day mortality, and the secondary efficacy outcomes looked at clinical failure with a composite endpoint and microbiologic cure if they survived 48 hours. So overall, there were 213 who received colistin and placebo, and 210 who received the colistin combo therapy. And just for some details on who was in the trial, the most common pathogen was Acinetobacter, so 77%, and the most common infection type was pneumonia at about 71%. And the authors found no difference between colistin with meropenem versus colistin monotherapy with respect to the primary outcome of 28-day mortality or the secondary outcomes of clinical failure and microbiologic cure in patients with pneumonia or bloodstream infection. I will note there was a reduction in the 28-day mortality with combination therapy for CRE, so 32% versus 17%, and for Pseudomonas at 43 versus 25%. But it was technically underpowered to really look for differences in the subgroups. And then I think the other important takeaway is there was a high rate of AKI. So about half of patients had some impact of on their kidney function. So I think comments for this, one, I think it's hard to capture sick patients in these settings. And that's where we kind of hope probably the most that combination therapy helps improve outcomes. I thought it was interesting. Actually, only 5% of the study participants had bacteremia with pneumonia. And I think the other interesting thing is that they transitioned from imipenem to meropenem once it became generic. And the meropenem dosing in the trial was 1 gram Q8 over 30 minutes. But for those who have read some of the newer AMR guidelines, it suggested that you can use the meropenem at the higher dosing, so 2 grams IV Q8 over 3 hours, particularly for CRE when the meropenem MIC is less than or equal to 8. And so that's sort of in the guidelines now for options where you don't have one of the newer beta-lactam, beta-lactamase inhibitor combo drugs. So not quite the dosing that we now are sort of suggesting to use. And then, since the trial was started, because it's been collected over a long period of time, we certainly have several new medications that could be used with colistin or on their own. So ceftaz-avi and ceftoltazobactam and imipenem relebactam and meropenem vaporbactam and cefiderocol. That said, I think these drugs are not available everywhere. And so this is still kind of an interesting question. So I will leave it there and say this is a good, I think, Journal Club article for those who are on the hunt for a new paper.
Okay. The article Outcomes of Ceftriaxone versus Anti-Staphylococcal Penicillins or Cefazolin for Definitive Therapy of Methicillin-Susceptible Staphylococcus aureus Bacteremia was published in Open Forum Infectious Disease. So for background, the common wisdom is that methicillin-susceptible Staph aureus MSSA bacteremia requires weeks of IV antimicrobial therapy for treatment with either anti-staphylococcal penicillins or first-generation cephalosporins. We've learned over time that from an evidence-based perspective, first-generation cephalosporins may even be the drug of choice, but and here we go into it. Use of these agents in outpatient settings requires frequent dosing, along with close toxicity monitoring through the duration of therapy. Ceftriaxone, I'm going to say, seems an appealing alternative given daily dosing and tolerability, but efficacy in this setting remains uncertain. So, for starters, this is a retrospective cohort study, so not an RCT. A total of 223 patients with the accompanying characteristics met study criteria. 37 received ceftriaxone, so that's about 16.5%. 186, that's 83.4%, were treated with the cefazolin or the anti-staphylococcal penicillins. That's going to be your nafcillin, your oxacillin. 90 and 30-day treatment failure were higher in those treated with ceftriaxone as definitive therapy. 27% versus 8.1 compared to cefazolin or ASP, 8.6 and 3.8. This does reinforce the idea that ceftriaxone is an inferior choice. So just to run those numbers again, 90-day treatment failure with ceftriaxone was 27%. With your cefazolin or ASP was 8.6. 30-day treatment failure was 8.1% compared to cefazolin or ASP at 3.8. So we're really seeing a 2 to 3 fold increase in treatment failure. So as convenient as ceftriaxone might seem, this study would not support going down that convenience path.
We were just talking, we really discussed not this paper specifically, but the debate on ceftriaxone and MSSA coverage. So always interesting. Well, I have another one. I feel like all my papers were from OFID this session, but a turtle disaster, salmonella, cardiovascular implantable electronic device infection. So this was a cool case report. It was a case of a 60-year-old with recurrent salmonella bacteremia leading to cardiac device infection, which that is pretty rare. And then it was complicated by non-susceptibility to ciprofloxacin. And so to point out, the patient lived with 3 dogs, 6 ferrets, and 3 turtles. And so this is, I think, a good reminder that salmonella has been primarily associated with poultry, eggs, dietary exposures, as well as contact with reptiles and amphibians and live poultry and other pets and pet foods. And so the turtle-related salmonella outbreaks are a re-emerging issue. And specifically in the recent multi-state outbreak of salmonella that specifically was related to pet turtles, the little ones that are under 4 inches are sort of the particular issue. And I really enjoyed that they noted the patient described their turtles as the size of a silver dollar. So we've actually had several cases of salmonella. I just had one this week. Fortunately, did not have complications quite as extensive as this, but don't forget to ask about the turtles and the reptiles.
All right. Yeah, there was a big python when I was in Africa recently, and I was quite afraid of the salmonella, so I kept my distance.
Yeah, that's
The
it.
article Evaluation of serotonin syndrome with linezolid and serotonergic agents at an academic medical center published in Sarah? Open form
OFID.
infectious disease, which whenever I pull an article from OFID, I remember Steve Goff at Columbia, giving me a hard time. Is that a real journal? I'm like, yes, it is a real journal, Steve.
I have to actively try not to pull all my articles from OFID because they tend to grab my attention.
No, they're great articles as an individual who has published there. This reinforces what I think has been consistent in the literature. In this single center retrospective study, right? Caveats there, with 1,743 patients, they reported that of those receiving linezolid, 43.2%, 16.2%, 5.7%, 1.4%, and 0.5% received at least one, two, three, four, or five concurrent serotonergic agents, respectively. Only 0.11% were identified with serotonin syndrome or serotonin toxicity, reinforcing that serotonin syndrome among hospitalized patients receiving linezolid with other serotonergic agents was exceedingly rare, even among those who received multiple and more potent serotonergic agents. All right. Fungal, the article, a randomized placebo controlled trial of preemptive antifungal therapy for the prevention of invasive candidiasis following gastrointestinal surgery for intra-abdominal infections, was published in CID. Interesting as this exploratory randomized double-blind placebo controlled trial in 124 placebo and 114 mycofungin treated patients that assessed a preemptive antifungal approach with mycofungin, 100 milligrams per day, in ICU patients requiring surgery for intra-abdominal infections did not provide evidence that preemptive administration of an echinocandin was effective in preventing invasive candidiasis in high-risk surgical ICU patients with intra-abdominal infections.
I like this because I feel like I feel like this question comes up a lot clinically. All right, so my next one, I also really like this one. This is probably my other favorite from today. In CID, risk factors and outcomes of invasive aspergillosis and kidney transplant recipients, a case control study of USRDS data. So this is a retrospective case control study that used a renal data system database. So that was that acronym I just mentioned, USRDS, to look at those who had a kidney transplant between 1998 and 2017. They compared characteristics between invasive aspergillosis infected patients and their matched uninfected controls, and found that typically invasive aspergillosis was diagnosed at a median of 22 or so months after their kidney transplant. And some of the risk factors that they identified were Black or African American race, duration of pre transplant hemodialysis, higher comorbidity index score, Elix Hauser comorbidity index score, weight loss, chronic pulmonary disease, need for early post transplant hemodialysis, and history of CMV infection. And so the odds increased by 23% per year of HD duration prior to transplant. So it's interesting. I don't think we totally understand this, but perhaps it is related to prolonged antibiotic use in this setting, the fact that they have intravascular catheters, or I think, as they discussed in the discussion section, that maybe this is just a surrogate for the duration of their kidney dysfunction before transplant and some of the subsequent immunodysregulation that we probably still need to better understand. And then, similar to some prior studies, they found that allografts from living donors were protective for aspergillosis infection. And then I think the last thing to note is that, and probably the most important takeaway, invasive aspergillosis was a very strong predictor of 1 year mortality with an adjusted hazard ratio of 5. And Infection was also associated with a 1-year allograft failure with an adjusted hazard ratio of 3. So pretty significant. I really liked really liked this paper, but it's kind of biased to my interest.
All right, I can see where you're headed. The article, predicted performance of gram staining of catheter tips for Candida catheter-related bloodstream infections, published also in open form infectious disease. Here, the authors analyzed 2,462 episodes of suspected catheter-related bloodstream infections, the sensitivity, specificity, positive, negative predictive values for detecting Candida, CRBSI, Candida related, Candida catheter related bloodstream infections. When the letter acronyms become 5-letter acronyms, I think we're getting a little out of control. But anyway, by gram staining tips was 66.1% for sensitivity, 99.4% for specificity, 84.4% for positive predictive value, and 98.4% for negative predictive values. They suggest that gram staining may be useful. All right.
We both picked the same one. This paper, I didn't realize. Yeah, I thought this one was quite interesting.
I should have let you. Do you want to go ahead?
No, you had to take the OFI. Otherwise, I'll only talk about OFID papers. Yeah, it's interesting. I think it was worth pointing out that most of them were CVCs. Only 2% were PICs, but still cool.
No, I think that's actually important. All right.
Yeah.
Well, now we are into parasitic, and boy, was my trip to Africa great for seeing a lot of these cases. So be sure to listen to This Week in Parasitism, our upcoming episode. We're going to have a fantastic guest. Actually, the next several, we've got like a string of great guests coming on to This Week in Parasitism. So stay tuned. Very exciting unveils before us. But the article, Integrative Genetic Manipulation of Plasmodium cynomolgi reveals multi-drug resistance -1 Y976F associated with increased in vitro susceptibility to methylquin, published in JID. Now, a little background, I think, is required. The Plasmodium cynomolgi, a simian malaria parasite of southeastern Asian macaques, has long served as an excellent model for P. vivax. More a reminder than anything that we are seeing increased resistance to current therapeutics, and we'll need to stay ahead of this, or it could have profound effects on these malaria endemic regions. Also, I saw some neurocysticercosis while I was hanging out in Uganda. I'm sure my buddy Chris Coyle would be jealous, but the article, Clinical Characteristic of Patients with Calcified Parenchymal Neurocysticercosis and Perilesional Edema in a Large Non-Endemic Cohort, was published in OFID. I was not surprised to see Christina Coyle there among the authors. They reported 180 patients identified with calcified parenchymal NCC, neurocysticercosis, that had perilesional edema, a frequent phenomenon among the NCC patients. The suggestion is that that antigens may be leaking from calcified lesions, leading to this inflammation, but the true pathophysiology is not known. But just a reminder that those calcified lesions may actually be dynamic. I think the article, The Impact of Sequestration on Artemisinin-Induced Parasite Clearance in Plasmodium falciparum malaria in Africa, published in CID, is actually important. When I was in Uganda recently, I saw that a couple things were happening. Clinicians were sharing that they noticed a delay in the drop in parasitemia in malaria patients, that they were interpreting as artemisinin resistance, and were either starting to use higher doses of artesunate, for those listening, or adding IV quinine to the treatment. Perfect in that this study is right out of Uganda. Here, the investigators analyzed 133 P. falciparum malaria patients included in an in vivo study on artemisinin efficacy in northern Uganda in 2018 and 2019. The parasite clearance half-life was estimated from peripheral parasitemia after artemisinin monotherapy, and here they reported, in addition to some noted artemisinin resistance, intensive sequestration was also delaying parasite clearance. I was going to sort of make a little bit of a quip about I'm not sure how evidence based adding the quinine is to the IV artesunate may have actually be associated with more harm and side effects, but I'll leave a link into some of the earlier literature on that, as well as the link to this important paper.
Nice. Well, I would take us into our last section, miscellaneous. Um, another paper from OFID. But I love this one. And the first author, Dr. Wendy Stead, I adore as my role model. But wondering if I'd get there quicker if I was a man. Factors contributing to delayed academic advancement of women in infectious diseases. And I mean, the title has a Taylor Swift quote, and it doesn't really get much better than that.
So I that made me think of Taylor Swift. So it's not just me. Okay.
No, it's actually a reference to it.
I'm a huge Taylor Swift fan, by the way.
Love it. So this study was based on some semi-structured focus group discussions with American academic ID physicians to explore perceived barriers and facilitators to academic advancement. And so they assigned some of these groups based on academic rank and gender, and found that some of the barriers to equitable advancement included interpersonal and institutional gender bias, including workplace harassment, difficulty balancing demands of family life with work life, and gender differences and approaches in negotiation strategies. And so it goes without saying, we don't really have time here, but that the gender gap is pervasive and it's significant. And I really strongly recommend that people check out this paper among many of the other papers that were cited and put forward by this group. I think what is particularly impactful is the representative comments. So there's a table 3 that people can read through. But I will mention that there's a framework that they put in the paper for what steps we can take or approaches. And so it's ESIR. So E, enforce protective policies to create a culture of safety and ensure zero tolerance for unprofessional behaviors and harassment. S, support faculty and trainees. So that might mean virtual interviews, it might be help with negotiation skills training, and it may be things such as clean and accessible lactation spaces. The I, implement equitable policies, and in particular, they put a focus on parental leave. And then R, recognize leader biases and take measures such as requiring implicit bias training. And so I will end with, do not penalize assertive behavior in women and create culture where support is proactively offered so everyone can thrive.
Okay.
I love it so
Very,
much.
very important article. And Taylor Swift, if you're a listener, I don't know if she is. So all right.
Yeah, Taylor, just give us a shout out.
Okay. I think this is an important article as well. Well, for all physicians, I'm not sure how much for infectious disease physicians, but characterization of problematic alcohol use among physicians, a systematic review published in JAMA Network Open. Basically, what we're seeing here is reported problematic alcohol use increased over time from 16% in 2006 to 26.8%. 7 of 19 studies, 37% identified that problematic alcohol use was most common in males than females. So think about that when you're promoting someone. If you promote a woman, she's less likely to be an alcoholic. Interesting results on which specialties had the highest rates of problematic alcohol use. And I will say this is coffee, just by the way, if people are wondering.
I picked a paper because it's ID relevant and put it in the miscellaneous section, but it's sort of like technically not an infectious disease. So in OFID, alpha gal syndrome and ID clinic, a series of 5 cases in central North Carolina. So for those who didn't just study for boards, and this may not be as fresh, I'll give a review. Alpha gal syndrome is an allergy to galactose alpha 1,3-galactose, an oligosaccharide in mammalian meat. So you may have heard the other term for this, like red meat allergy. And so the story that we're sort of you read about is leading to angioedema, urticaria, and anaphylaxis within about 3 to 6 hours after ingesting red meat. But it could also just be GI symptoms and fatigue and arthralgias. And so it's thought that the alpha-gal antigen is transmitted to humans through saliva of a Lone Star tick, which can then stimulate an IgE antibody response and lead to this allergy, usually starting somewhere around a month or so after the bite. And so this is a series of 5 patients who went to the UNC ID clinic and were subsequently found to have alpha-gal allergy. And so just a great reminder that this can easily get referred to ID clinic, particularly if they have a story of persistent symptoms after a presumed tick-borne infection. And a few keynotes that the authors mentioned that I thought were helpful. Often the patients seem to recall inciting tick bites as particularly or sort of unusually erythematous and pruritic. And none of the patients that they met actually had anaphylaxis, but rather sort of more generalized GI symptoms or arthralgias or brain fog. So it may not be that perfect anaphylaxis story that we read about in the textbook.
Okay, and to wrap it up here, I'm not sure where this really fits in, but efficacy and safety of azithromycin versus placebo to treat lower respiratory tract infections associated with low procalcitonin, a randomized placebo-controlled double-blind non-inferiority trial published in the Lancet Infectious Disease. Here they ask the question of giving people a sugar pill or placebo is just as effective as giving unnecessary antibiotics. And surprise, surprise, they conclude placebo was not non-inferior to unnecessary antibiotics, azithromycin, in terms of clinical improvement at day 5 in adults with lower respiratory tract infection and a low procalcitonin concentration. After accounting for both the rates of clinical improvement and solicited adverse events at day 5, it is unclear whether antibiotics are indicated for lower respiratory tract infection and a low procalcitonin concentration. So for all the docs out there.
Excellent summary. That brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We'd love to get your questions, comments, and paper suggestions. Keep them coming. Send them to puscast@microbe.tv. And consider supporting the science shows of Microbe TV by going to microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts. This Week in Parasitism, This Week in Virology, clinical updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.